Hi, everyone. Good morning, or good afternoon. I'm Naima Joseph. I'm a maternal fetal medicine physician at Boston Medical Center, um, and which means that my clinical work really seeks to improve or reduce perinatal adverse outcomes in patients who are already at high risk of having those poor outcomes. Um, and this is kind of joins with my research work is how can we leverage health systems to improve and reduce perinatal morbidity, especially amongst Black birthing patients and birthing patients of color. I think it's not surprising to us. We know the burden that is in the United States, that maternal deaths are unacceptably high, just writ large across our population, but that Black women have a 2 to 3-fold increased risk of death around the time of childbirth or in consequences following childbirth for up to the year after delivery. What we also know is that although the rates are unacceptably high, what we also see there are severe maternal morbidity events, which are more proximal indicators or near miss events that also contribute to short-term and long-term adverse outcomes and disability amongst our patients. At Boston Medical Center, and many of us have talked about our roles there, but it is a primarily safety net institution where we take care of economically and racially disadvantaged patients who already enter their pregnancies at an increased risk. And what we've interrogated within our system is that all things being equal, we still have up to a 2-fold higher risk of severe maternal morbidity in our population, and that a lot of that is driven by preeclampsia or cardiovascular disorders that occur during the pregnancy. So our team has taken a learning health systems approach, which essentially builds upon those initial quality frameworks first established by Donna Medina and expanded upon by Margaret Crook, that looks at what is a health system supposed to deliver to a population. At baseline, that's health, but also trust utilization, reduction in financial expenditures. And the next kind of iteration of this learning health systems is how can we decrease that dissemination to implementation timeline, which traditionally has been thought of as taking 17 years. How can we rapidly use innovative data to improve care amongst our population and interrogate it and make sure we're delivering on that promise of healthy populations? So knowing that preeclampsia is a driver of health, of poor outcomes in our population, and also knowing that preeclampsia, the model of this disease is that it's quick, it's sudden onset, and doesn't really fit in the current paradigm of prenatal care in that over the course of 40 weeks, many patients will have up to 12 to 16 visits. But that doesn't allow for detection of preeclampsia in our patients. We implemented a remote blood pressure monitoring program where patients are taught to check their blood pressures. They're paired with a nurse navigator who provides an educational visit as well as follows up on the blood pressures. And then patients who are at high risk for developing preeclampsia do start to see or develop concerns with their blood pressure during their pregnancy and beyond are linked to a maternal fetal medicine specialist, a pharmacist, and really targeted connection to their primary care doctor. And so I'm excited because we're just at the beginning of this, but it's funded through ARC and PCORI to basically evaluate what the effectiveness of this blood pressure monitoring is on our patient outcomes using quasi-experimental designs, historical cohorts, as well as a contemporaneous cohort through a target emulation trial, as well as paired with qualitative work to understand the implementation and whether or not this meets the needs of our patients. Thank you so much.